Good evening. I want to welcome you to the Doctors, Hospitals, and Healthcare Providers panel this evening. I'm Dr. Gary Montefico, and I'm with Pepperdine University. You heard my name a little earlier in the evening. I'm the new Associate Dean for the Executive Programs, Executive Education, and the Fully Employed Graduate Programs at Pepperdine. So I'm delighted to be here tonight. When invited to participate, I was very excited and very eager because I actually came to academia a little bit late in my career. It's sort of an encore career for me. I spent the first 25 years of my career in healthcare on the provider side and services side. So it's an area that I'm very passionate about and spent most of my career in. So I'm delighted to be here. As a matter of fact, one of our panelists tonight, Tom Preslock here, who is the CEO of Cedars-Sinai, probably 25 years ago, I think it was. Tom and I were both young executives. Well, we still are.
Both young ones.
And worked together on the development of the behavioral medicine services for Cedars-Sinai in a former lifetime. So at any rate, I'm delighted to be here. I want to introduce our panelists. I'll be brief because I want to devote most of the time that we have together, which is somewhat limited, to our panelists' remarks. So, as I mentioned, to my immediate left here is Tom Preslock, who's the Chief Executive Officer of Cedars-Sinai Medical Center. Prior to becoming the CEO, and you've been in that role since 1994, I believe. Right. And before that, he was Executive Vice President and Hospital Administrator for multiple service areas within Cedars-Sinai. And of course, those of us from Los Angeles know Cedars as a paramount medical center that's world-renowned and certainly consistently in the top preferred medical centers in Southern California and around the country. So congratulations to that, Tom. We're delighted to have Tom with us tonight. Next to Tom is Wendy Songer, who is an alumni of the MBA program here at Pepperdine. And Wendy is the Director of Clinical Operations at Mattel Children's Hospital at the UCLA Health System. Has spent about 22 years in health service delivery, both in private and academic settings, and her focus has been a lot of training, and she's trained over hundreds of faculty, residents, and allied healthcare professionals in the business of medicine. So we're delighted to have you join us tonight, Wendy. Thank you much. And then next to Wendy is Dr. Shirley Suda, who's the Area Medical Director for Kaiser Permanente Woodland Hills. She's a board-certified surgeon, and she's been with Kaiser Permanente for 20 years, and she's been the area medical director for the last 7 years. And she's responsible for all overall patient care and the management of primary and specialty care services for Kaiser Permanente. So again, please extend a warm welcome to our panel. Would you like to take a moment and add anything to your introductions?
I think you covered it all for me. Thank you very much.
I'm first very pleased to be here. It's been a long time since I've had in relationships with Pepperdine, so I'm very pleased. Thank you for inviting me.
I see that Mr. Murdock left already, but I was going to tell them that we at Kaiser Permanente, we also believe in broccoli. Yeah, sprouts.
So there are a couple of things at the reception I didn't quite recognize. So I've got to retrain my brain. If I don't recognize it, it's still okay to eat. Anyway, well, thank you all for being here. I'm going to ask our panelists a series of questions and give them a chance to respond to that. And then if there's time, we'll open it up for questions from the audience. But the first thing I want to do is to ask you, if you were to take a snapshot and think about your organization and how it was 10 years ago at the turn of 2000, and compare that and contrast it with 2010, what have been the major changes you think you've encountered, and major changes that have occurred for you in healthcare?
Tom, you want me to go first? Well, I guess a couple of things come to mind. These really are top of mind questions. Right? And that was the sales pitch to us, was these would all be top of mind questions. Yeah, I guess a couple of things come to mind. One is a much more intense environment. And when I say intense, I mean both medically, as far as the acuity level of the patients in the hospital. Also intense from a regulatory standpoint. amount of government and other regulations that have come into healthcare during the last decade have grown significantly. Much more intense from an economic pressure standpoint, kind of reflecting significant increases in cost for a variety of reasons that we can talk about later, combined with continued downward pressure on the revenue side. And then just, I think, increased intensity with regard to institutions and physicians being able to deliver on the whole question of value.
I have to agree, and I can also add, I think 10 years ago we had an easier time of recruiting physicians to our practices. In pediatric medicine and family medicine, we are certainly challenged by that today. Our patient census is growing. Our payer mix is quite different 10 years ago, as compared to today. So those kind of just big stand out in my mind.
I would say at Kaiser Permanente, there are many things that are the same, and there are a lot of things that are very different over the past decade that I've been involved with this organization. And the things that are the same are the things that I came to Kaiser Permanente for as a young general surgeon just getting out of my residency, and that was the integrity of the organization, the patient centricity around patient care, and really the values of our organization being around being able to deliver the highest quality of care. And those core values of our organization have not changed in the past decade. I would say as an organization, we have been revolutionized. We were revolutionary in when we were organized as a prepaid health plan, but over the past 5 years, we've revolutionized our care. With the addition of the electronic medical record, it has changed the way we practice medicine. We are able to deliver a much more efficient model of care that centers on what we believe is still at the core of healthcare, which is preventive care, as well as chronic disease management. And the electronic medical record has helped us to be able to do that. But our core values around patient centricity, when it comes to the quality of care being first and foremost, that hasn't changed one bit.
Yeah, I think you bring up a good point. Certainly, the value of care delivered to patients, and patients being centric is a core principle, I think, of all healthcare services. But you have mentioned the changes in time. You mentioned the regulatory and economic challenges that have occurred. Both of you mentioned delivering value and quality to the patient. How has your company's positioned the cost of the delivery of services that you sell and provide based on the passing of the recent healthcare legislation? How's that impacted?
Well, I think that every organization is developing a series of responses. Although I have to say that thematically, I think they represent a lot of what has been experienced over the past 10 years as far as trying to deliver value in healthcare, which means trying to do what we can to address the issue of the rate of increase in the cost of healthcare, and then in parallel with that, making sure that the quality of care that is rendered is increasingly improved, and from a national standpoint, seeing healthcare be more uniformly of high quality around the country. So I think the way I've described the impact of health reform within the organization and elsewhere is really kind of turbocharged the kind of trends that we've seen, at least here in California, for the last 10 years.
I do feel that we have a greater challenge, but I will say that over the course of my career, I've looked forward to each incoming class of residents in teaching the business of medicine and understanding how to make a living. Because if you ask a physician, how long, or have you ever had a class or a course or an elective in how to earn money once you graduate, once you open a practice, where does that all come from? So this is a big piece of where we're going with this, to educate the physician that what is an RVU, where do we come, to all of these new acronyms, and where are we going with all of this? So I think that the education of all of our practitioners and clinicians, it's a big deal. And being able to provide those services and keeping positive just a positive, environment. Our physicians, our senior physicians, are boasting and very pleased about, a subsidization from government for family medicine, for pediatricians, that we're actually going to get paid, a bit more for our work in preventative care. And this is, it's motivating, and we're kind of just around that piece at this moment.
If you ask the physicians in my medical group what they think about healthcare reform, you hear the diversity of opinions. And I think you have to go back to think, what is healthcare reform? Why do we need healthcare reform? And what was the reason for passing a healthcare legislation? And it's to address some very serious deficits within our healthcare. Number one, around access, and the 50 million people across the nation who do not have care. And do not have access to that care. It's about the escalation of the costs of health care, and that double-digit inflation that's reaching, paramount proportions of the GDP. And then finally, the impression or the perception of the dubious quality of care that currently is delivered in the current system. So when you go back and look at those three factors, which are really the drivers of healthcare reform, then how are we going to address that as an organization? And Kaiser Permanente is looking at all the pieces of that legislation and complying with those pieces. But when we go back and discuss this among our physicians, we talk about really how healthcare reform is going to help us as a group of physicians and as an organization be able to provide what we want to provide, and that is really a model for the nation around healthcare, which is an integrated, well thought out, organized structure around medicine that provides accessibility and that looks for affordability within that realm of the organization and within our structure. So with that, we take on the challenge of healthcare reform, and we look forward to it.
So if I ask you to take that a step further, and let's talk a little bit more specific, what do you think are the primary drivers of the sort of double-digit annual cost increases, the escalation and so forth of costs that you were mentioning? And if you could, what do you think medical professionals and hospitals should do to slow this trend, or perhaps better manage the growth of that escalation?
Well, as a physician, it would be easy for me to blame things like the high costs of technology and robotic surgery, or the high costs of pharmaceuticals, and and blame the hospitals for their high costs, and other, or even malpractice insurance rates and things like that. It would be way too easy to blame other factors. But I think we really have to look at how we deliver medicine as really the core factor that has caused the high increase in the rate of health care. And basically, it is the current system lacks a vertically integrated structure that allows for physicians to share information in an efficient, easily attainable model through the electronic medical record to be able to coordinate care. And as an organization and and Healthcare for America, we have to look at using that system to be able to stress the preventive care of immunizations or screening for cancers, and then also to look for disease management for the chronic diseases such like diabetes, congestive heart failure, asthma, coronary vascular disease, those things. So if we want to be able to deliver better care in a much more cost-effective manner, it's prevention and disease management.
Prevention, disease management. Wendy?
For past couple of years, we've basically looked under every rock. What are we doing? Where's the waste? Okay, so a lot of lean thinking going on in academia right now, in the medical centers. So you will see, we've hired consultants to see what are we doing wrong? Why do we have, only a 2 patient, per session turnover in our ambulatory centers, per morning session? And it's very true. I mean, where's the weight? Where's there's a blog here as we go through and understanding what's happening and why patients are sitting in waiting rooms for an hour at a time. And then once they get into the exam rooms, they're waiting another half hour, 45 minutes, and these things we had to clean up. And we had to just kind of streamline processes so that the physicians were doing their job. They were seeing the patients. They were seeing, and the wait time. So it's not a 6-month wait to see a pediatric neurologist, which is what it is currently across the nation today. So we have had to do a lot of looking within to be sure that we're as efficient as possible.
I think if you look at the question of what are the drivers of healthcare costs at an aggregate level, they really break down into two things. One is the increased cost to produce the care that's being provided and the rate of increase there. I'll come back to that in a minute. And the second is the increasing utilization of services. With regard to the input costs themselves, within the hospital setting, just to take that, and that's about 30% of all the spending nationally. The challenge in the hospital setting is that 60% of the cost in a hospital setting are for people. And the difficulty with regard to controlling costs in that area are twofold. One, there are severe chronic shortages in just about every position that is utilized in a hospital. And so the laws of supply and demand are such that the cost of staffing a hospital are going up 2 to 3 times general inflation just because of those kind of factors. The other contributing factor is that the hospitals are under a severe regulatory structure, and so there are either literally laws that drive what the staffing in an institution is, or if not laws, regulations that largely imply and therefore limit the ability to innovate in the organization of services. So those are some of the challenges on the input side. On the demand side, I think as was stated earlier, there are issues related to how care is organized and how it's provided. There are issues on the demand side, frankly, from the public. A friend of mine has a nice way of describing it. He said, Californians sometimes think death is optional, and I think that can summarize the demand side that we see in the healthcare arena. But there remains the issue and the challenge that remains, I think, on the utilization side for everyone who works in healthcare is trying to identify and make sure that the things that are done are both appropriate and effective. And part of the challenge in medicine is being able to make sure that one knows that and can address it on the front end. It's very easy to look back and answer the question, what would have been effective or not. I have a lot of respect for a number of reasons of physicians, and among them is the judgment that they have to bring, both combining the best knowledge in the field of medicine, so-called evidence-based medicine, but then applying their own judgment and knowledge of the patient and other factors. So I think there are a lot of complexities on the utilization side, but it is the area that I think in the health reform legislation, there are a lot of hopes, frankly, being placed on the ability of medicine by changing the payment level to align the kind of interests that were described earlier. There's a lot of hope in the health reform legislation that by getting a better handle on the utilization side, we'll have an ability to impact the rate of increase in cost.
So you both have mentioned disease state management and utilization. And so in addition to the cost management that all three of you mentioned, if we were to think about more complex medical conditions, obesity, heart failure, and blood pressure and other diseases, we've been practicing disease state management or making efforts at it since, at least the mid-90s and so forth. What are your institutions doing around outreach, awareness, or educational programs, or what could hospitals and healthcare professionals be undertaking towards that, to be more direct or assertive with the utilization side?
By the way, Tom, I think according to Mr. Murdock, death is optional.
Right.
But regardless of that, what Kaiser Permanente is doing around outreach and health maintenance and health promotion, we align our goals. throughout the organization, both on the inpatient and outpatient side, around the clinical strategic goals. We have clinical strategic goals, and we set goals for ourselves as an organization. Currently, and they're along the lines of being healthy, staying healthy, and attaining health. For example, around being healthy, we align our goals around for cancer prevention or cancer early detection. So currently our three major goals for cancer early detection are around pap smears and cervical cancer, colonoscopy or for colorectal cancer screening, and also for mammogram and breast cancer screening. So we set our goals as an organization, and then we measure how we do, and then we always increase the goal on an annual basis, okay? And we outreach to our patients. We know when a patient is coming into our medical center who needs a mammogram. And so if she shows up, so the 51-year-old woman who needs the mammogram shows up in two places in our medical centers. Number one, in optometry, because she can no longer read anymore. And number two, she shows up in dermatology because she doesn't like the little spots that's showing up. So when she shows up to either one of those places, they are going to, when they open up Health Connect and the electronic medical record, a care gap will come up on the screen, which will say, this woman needs a mammogram. And we've trained our receptionists, we've trained our nurses, we've trained even the dermatologists to remind that woman that she needs a mammogram. Then we send her upstairs to the 3rd floor, and she can get it that day. And that's how we can capture our patients where everybody's involved, and we're all incented. The receptionist, the nurse, and the doctor are all incented to get that mammogram done today so that that patient achieves their preventative screening. We do this along the lines of our clinical strategic goals around chronic disease management. So the current 5 that we are monitoring this year are about hypertension control, hemoglobin A1C in diabetics, LDL in diabetics, LDL in coronary vascular disease, and smoking cessation. So again, when a patient shows up anywhere within our system, you open up Health Connect, it's right there in your face in bold yellow letters. This patient needs hypertension control, and we have a care management team that essentially, if they're seeing the dermatologist who doesn't really treat hypertension, will get sent over to our hypertension clinic and is monitored. And that nurse practitioners, our whole system is set around that patient to make sure that that patient gets their blood pressure controlled. So we outreach, we inreach, we have our systems designed so that everybody focuses on getting the preventive care done and that the goals are met along chronic disease management.
In answering this question at Cedars-Sinai, I first have to give you some background because unlike Kaiser, our physician component is different. And what I mean by different is we have about 350 of our medical staff who are full-time faculty, similar to the faculty at UCLA, another 110 who are in a multi-specialty medical group that's affiliated with the institution, and then a large number of private practitioners. So in answering this question, in part, it does vary from area to area. So with regard to the medical group I was describing and the faculty, we're in the process of installing the electronic medical record to do the kind of things that Dr. Suba was describing a minute ago. From an institutional standpoint, on the hospital side, where most of our focus has been through things like making sure that the discharge planning process begins at the time the patient literally arrives at the institution, and a whole series of actions around that. More recently, some of the other things that are taking place are essentially putting hospital resources out into the continuum of care to deal with issues that might relate to unnecessary readmission, avoiding having patients coming back from a skilled nursing facility having acquired an infection, which essentially creates an extra cost to us to take care of that patient when they come back. And then also more recently, working with patients who have a particular disease. Congestive heart failure is probably the best example, where nurses and other kind of outreach strategies to work with patients who are being discharged with congestive heart failure to make sure that they understand when they get home what the orders were, what the prescriptions might have been, and they have the social support system in order to implement it. Again, the idea in that particular area is built around trying to avoid unnecessary readmissions.
What comes to mind, we have many preventative care programs in the area of pediatrics, and more so for the possibly uninsured patient than almost for the insured patient today. Many of the health plans have decreased a lot of their benefits for preventative care, so we struggle with that daily. On another note, our cancer survivors, pediatric, that have gone through cancer, as young children, well, wonderful news, we have great survival rates these days, and we've created many transition programs for these kids, adolescents, get to be 18. Where do they go from here? They need to get a job. They may not have health care yet. How do we transition them into medicine, into a preventative lifestyle? And that has been a big thrust this past, well, I'd probably say 5 years, that we have clinics, designed for the teenager to come in and to understand, how longevity will affect them. Maybe their body has had, they've been through the mill for several years. So this is a big part of work at UCLA Children's Health Center and also at Mattel Children's Hospital. Also, we have our wonderful Breathmobile going to all the schools in the LA and Long Beach, Orange County area, where we're treating children at the elementary school level for asthma conditions and for allergy, food allergy testing and so forth at no charge. So the parents, the teachers, the school nurses are all involved in the care and prevention of future problems with our children. Those are the main things that come to mind with that question.
So how does indigent care and high volume emergency room care impact the overall quality of care and the cost structures that you're faced with? How do you balance that pressure, that public need, along with your own organizational needs?
And that is very challenging at this time. We're very invested in trying to limit or decrease, I should say, our emergency room admissions. UCLA has built a new hospital just over 2 years old, and the hospital has been full since the day it opened their doors. So we struggle with that, and preventative care is a big part of this to try to keep patients, there's not a need then for emergency room care. I think that we can all look at the indigent population. Ours certainly has increased percentage points over the past 5 to 10 years. I know that our population of Medi-Cal in California, Medicaid across the country has increased, and our knowledge of how to recoup any of the monies that might come back to us is challenging as well. So I've had a big part in that in the past 20 years of learning how to do this correctly, and there are ways to benefit and be able to pay our staff and physicians.
As a physician, when a patient reached the emergency room, it was pretty invisible to me whether or not they were a member or non-member, whether or not they had insurance or didn't have insurance. As a general surgeon, I went down to the emergency room and took care of them regardless of what their insurance was. And so that was not a part of really the thinking of an SCPMG physician in the long run. I do believe that the issue of indigent care impacts the entire system of health care. And it boils down to, indigent care is no longer indigence. It's the everyday person now who cannot afford insurance, right? And we all know people who are well-educated, who have jobs that still cannot afford health care. And so I guess the indigent has been redefined by the escalating costs of health care. And that's what we try to address through one of our core values of being able to provide affordable health care. And that affordability challenge is there for every physician. And when a health plan and the hospitals and the physicians share incentives and goals as part of the core of their values, that's when you can become a much more efficient system that can still deliver very high quality care, that's convenient and easy, that's personalized, and that still stresses affordability so that there are fewer indigents to medical care. And I think that that's how we as an organization see this issue and want to move forward with healthcare reform.
I think when you talk about indigent care and its impact on things like the emergency department and its impact on the cost, I think you have to consider both uncompensated care as well as undercompensated care. The latter largely reflected in things like Medi-Cal payments relative to the cost, where in the state of California, Medi-Cal payments are on average probably 65% of what it costs. At places like Cedars-Sinai and UCLA, that number is probably 40% of the cost because of the higher cost services that get delivered in institutions like ours. The impact on the emergency department is in part a reflection of the larger system failures that we've had that hopefully health reform will address. But just to illustrate that point for you, about 10 years ago, we enlarged our emergency department, and in 1 year, the volume went from 50,000 visits a year to 75,000 visits a year, literally in 1 year. I'm still trying to figure out where all those people were going before we enlarged the emergency department. But I think it's important to recognize that for most hospitals, there is both a desire and a plan to deliver a certain amount of uncompensated care to fill in the holes, frankly, in the system that we have. And so we have an ambulatory care clinic that's set up at the hospital to care for the uninsured and things of that nature. Where it becomes problematic is when the larger system failures, either because of the uninsured or the difference between what it costs to provide care and what is received, becomes problematic. So again, in our own case, our community benefit, which is the term of art that's used in healthcare to define what it is that institutions do that represents uncompensated and undercompensated care. In the case of Cedars-Sinai, that's $275 million a year. A certain amount of that, as much as we can, we absorb. That's part of our mission and what we try to do. But at the end of the day, you have to run a financially viable organization. And so when people talk about the cost of commercial insurance, you asked about cost earlier, Gary, I think it's important to recognize what the cost is depends on where you fit in the system. And if you're commercially insured, there's a certain amount of commercial insurance premiums that does represent a cost shift as institutions try to stay viable in the system that we've had.
Okay, thank you. Many of the people here tonight are employers and run organizations and so forth. And I know one of the concerns that continually emerges is balancing kind of independent of costs, improved patient outcomes, for their folks. But at the same time, figuring out the criteria for how that quality of care or patient outcomes should be measured. Can you talk a little bit about what your institutions are doing relative?
Well, through the electronic medical record, we can securely look at employer groups' employees and know what they're spending on their healthcare dollar. And then we can look at that and analyze it and know, what percentage of their employees have diabetes, what percentage of those are controlled, such that we can help them to be able to manage those disease entities and be able to hopefully bring down their health care costs. So we have very sophisticated systems of looking at that, being able to show an employer group how we do it and what are the plans around doing that. And we do that along the lines of the preventive and the chronic disease management. So it's really through the power of the electronic medical record that you're able to get that information and be able to show an employer what they're spending, why they're spending it, and what they can do in their organization to be able to improve those. So if obesity is an issue, and they're spending a lot of money in obesity surgeries, or diabetes is the issue, or chronic or coronary vascular disease, taking those entities and being able to say, you seem to have a higher incidence of this disease with poor control, here's what we can do. We have invested in what we call our Thrive van, which can also go out to different employer groups to be able to help them be able to take care of some of those issues at the workplace. So really trying to outreach and help our employer groups be able to better manage their care and therefore better manage their costs.
And I think with this, on this subject, we've tried to embrace the quality of care for patients in general. As we mentioned earlier, and the environment that we are in, and the amount of, I would say, the volume of patient competing and also recurrent visits. We are seeing patients come back, 2, 3, and 4 times. Our employees, well, and I did mention to a couple of people earlier, we're in a union environment at the UCLA enterprise, which is, it has its challenges, but I will tell you, we have a very invested group of staff. We have motivated our staff this year more. I will say that we have created more incentivized plans and trying to have just have everyone enjoy and understand that they have a benefit in this sector, in this healthcare reform and so forth. We're asking all of our staff to take classes, and it will become mandatory for all of our nursing and administrative staff to have the same basic scripts when we're talking to patients, when we're caring for patients, so that the quality of care, will go further.
With regard to efforts to improve quality within the organization, a couple of things. First, there actually are a substantial number of quality measures of either an outcome nature or measures of the process of medical care that already exist, that are either requirements and are part of the payment system, either by the federal government under Medicare or under various contracts that we have with commercial insurers. And in point of fact, one of the challenges that I think everyone in healthcare is facing is actually kind of an explosion of these kind of measures, and managing the priorities of addressing those is an issue that I think everyone in the field is facing. Organizationally, the way we approach that, without going through each one because we could spend all night describing each of them, from an organizational strategy standpoint, our goals are very clearly stated and pretty simple. We're either at 100% or at the highest decile, or however relative performance in the entire field measured nationally is, and that's where Cedars-Sinai strives to be. And as Wendy was just saying, our incentive systems and all of the performance measurement systems in the organization are organized around that in order to try to achieve it. I'll give you one example of a very focused effort that we have underway. We have a particular campaign to deal with the issue of hospital-acquired infections. Now, our performance relatively around the country in that area was already one of the best in the country prior to starting it. We have a very specific campaign aimed at essentially zero hospital-acquired infections. And I'm pleased to tell you that in 5 of the last 8 months, we've had 0 central line bloodstream infections in the entire institution, not just in the individual units, in the entire institution. And it does demonstrate that it can be done. In the months where we didn't have 0, we had 1. But it does demonstrate that it can be done. It's a question of focus within the organization and making it a priority.
Tom, I hate to tell you this, but our last bloodstream infection central line at Kaiser Permanente Woodland Hills was January 7th, 2009. Mm-hmm. So it's been over a year. And, we are looking at really, looking at our systems to be able to prevent that. We also heavily involve our medical staff in making sure that we are providing the right care. When you provide the right care at the right time, then you prevent those bad outcomes. So whether or not it's community-acquired pneumonia, ventilator-acquired pneumonia, acute MI, when you're delivering the right care, so you have to drill it down to the point of interaction between the doctor and the patient, the doctor and the nurse and the patient. When the right care is occurring, then all the other measures fall in place. So we focus on the process of getting that done, and then know that the measure is going to naturally follow.
Well, congratulations to both of you. I mean, I'm happy to know infections are down. So, we've been talking about what your institutions and your organizations have been doing. If we take it a little bit step further and think on a broader basis, especially relative to what I'm sure many interests in the audience here tonight, what do you believe are the key policy issues that we're facing and that you would advocate for or want business audience such as this to be informed of?
Well, having just spent the last 18 months of my life as chairman of the American Hospital Association, heavily involved in the health reform effort, I would urge all of us to keep a focus on and make sure we do what we can to see that effort succeed. I think a successful implementation of the reform legislation is an important imperative both nationally as well as from a business standpoint. I think if I were to summarize the reform legislation, besides addressing the issues of access that Dr. Suda was describing earlier, which is an important part of the cost question because of the uninsured that we talked about earlier, what's been put in place really with the health reform legislation is what I would call a set of dials and levers that hopefully can realign the payment system in a way that does align incentives between doctors, hospitals, and others who are involved in providing care in a way that gives everyone the right incentive to try to make sure we're addressing the issues of both cost and quality. And the challenge, which this is not going to be an easy thing, so I don't want to understate that. It's going to be an enormous challenge for us to strike that right balance. But I do think that it is possible for us to impact the rate of increase in healthcare costs and at the same time see healthcare nationally be more uniformly delivered at a higher level.
Yeah, again, healthcare reform addresses the access issue, the affordability, but as a physician, I believe that the most important policy is around the quality of care. And what are we doing to promote that quality of care, and not just sick care, but well care. And I think that we have to really focus on what we can do to prevent the disease entities in the long run. And Americans are not waiting for the perfect health care insurance. They're waiting for the perfect health. They're wanting the perfect health care. And if we think of it in that terms, I think it helps us know what to do. And preventive care is really the key to, in my belief, that healthcare reform, that's our biggest opportunity. For example, within our organization in Southern California, our pediatricians, who normally all pediatricians will graft, the height and weight curve. And what our pediatricians picked up on is that, you usually see a nice linear little increase of height and weight. But in between the ages of 2 and 3, you should see a dip where the weight comes down and the height is still going up. When they don't see that dip, that is a harbinger of childhood obesity. And that they figured out that if between the ages of 2 and 3, if you don't see that dip, if you don't do something about it by the time they're 8 years old, that child is going to go on to develop childhood obesity, right? That leads to all the other medical problems later as an adult. So that's our opportunity. That's our opportunity. So back to what are the policies? We have to be able to take that knowledge, what we know, and do something at that point of time. So what we are doing at Kaiser Permanente is putting in dietitians in our waiting room in the pediatrics area where we've taken out, the video games and those kind of things and put a dietitian in there to talk to the families, because a child doesn't control what they eat, their parents do. And if the parents are giving Happy Meals as rewards and not, nice fruits and vegetables and other things, or a nice bike ride as a reward, that's where the issues occur. So as a physician, I think the most important thing around healthcare policy is really looking at the quality of care through preventive measures and through chronic disease management in order to build a healthier America. We also have an avenue through kp.org where our patients really can do a healthy healthy lifestyles assessment, and then they get reminders every now and then. Mine always comes up and says, "Are you taking care of your stress issue, Dr. Suda?" But so that we remind ourselves on a continual basis around the importance of taking care of yourself.
And we've stressed over the past probably 2 to 3 years the use of patient surveys and understanding that we need feedback from the community, from the families, from the patients. How are we measuring up?
How are we able to refer that patient's physician to another? Will you refer to your neighbor? And are we listening to policies that are being created? Is the knowledge there? Are we training our staff to understand, what is this reform all about? We started a program recently called CI Care, and on a good day, I can remember each one of those letters, okay? Basically connect, integrate, connect or communicate, ask, and seek information, and then I think the last one is exit courteously. So how are we working with our patients so that they feel that they are the only patient in your clinic? How are we absolutely making a newborn mom and dad feel like they're the only patient that this doctor has, okay? Because this is part of practice of medicine. And I think that the more education that we provide to our staff and totally embrace, the amount of time of their lives that they give to the practice of medicine. We all work 12-hour days. There's no such thing as an 8-hour day in the course of a hospital or an ambulatory clinic. And you have to have some investment in what you do and love what you do in order to stay and to thrive in the business of medicine.
I have tons more questions, but we're sort of pushing up against the edge of our limited time here tonight, and we got started a little late. But I do want to open it for just if there's one or two pressing questions for people in the audience who, yes.
You talked about lining up incentives. I heard from the Cedars what you're spending each year on indigent care. What's Kaiser spending each year on indigent care?
We have a very robust community benefit program. And I don't know the exact numbers, but we in the Woodland Hills service area alone, we invest about $300,000 in the community benefit in our local area. As far as the indigent care, I don't know that we can quantify that quite accurately as far as what we take care of.
How is this incentivized if there's no equity between the systems? He's talking $250 million in one spot, and you're talking $300,000 in the entire West San Fernando Valley.
No, that's just in the Woodland Hills service area. So the entire organization is much larger than that.
But he's dealing with one hospital, you're dealing with
13
13.
service areas.
Is that equitable?
Yeah, I'm not sure that we're comparing apples with apples here. And that, as far as the organization, you're asking how much do we spend on indigent care?
Each hospital system I've ever worked with can put a precise finger on how much they're spending per hospital site on uninsured care. You have 12 hospitals. I'd be just curious if you're even vaguely cumulatively in the ballpark as one hospital.
As a physician and a physician leader, okay, that is not my area of expertise. My area of oversight for Kaiser Permanente at Woodland Hills is really about the quality of care and the medical care delivery system. The hospital health plan basically, as far as bearing the costs of the indigent care, and so I just do not have that figure for you.
I'm with Kaiser as well. It's much more complex than just comparing, like the doctor said, to compare Kaiser to Cedars-Sinai. It's much more complex. There's Kaiser Permanente Health Foundation, Health Hospital, Permanente Medical Group, so it's rather complex. It's millions.
It's really not that complex. I do a lot of work with indigent care, and most organizations can be precise on what they're doing with indigent care.
I can get that number for you.
I'm the public affairs director, and part of my portfolio is the community benefits program. We spend about, organizationally, totally about 3% of our revenue on community care. And at Woodland Hills, we're looking at about 1.5. We include all the charitable care that 1.5 million in terms of the charitable care we provide. We participate in Med-Cal, Healthy Families. We have a program called Child Health Lab that we provide 0 to 18 in terms of the gap where they don't belong to healthy families, but they make too much money, that spend just a tad too much money, we provide care to that segment of the population, and we provide the care and provide it through Kaiser Card. They come in just like a regular member, and we provide the care from 0 to 18. So we have a robust community benefit program, not only providing grants to the community, the safety net clinics, we partner with them. We have our residents rotating at 3 clinics, and multiple 3 clinics. We have pharmacists that are rotating clinics. We have charitable care through the ER, and some of our actually uninsured patients come through our clinics as well. Not in an emergency situation, but clinics. And we have many other robust programs supporting the whole entire portfolio. We actually are focusing a lot on preventative care in terms of providing our latest program is Operation Splash to look at our environment. Is there a farmer's market in the local community for the community to provide fresh fruits and vegetables? Are we having swim programs in the local community? Are some of our local parks not having a swim program or swimming pools that are in indigent communities? So we have a kind of well-rounded portfolio to look at providing care for the indigent population.
Yeah, I think one of the things that this dialogue brings up is, one, not only the significance of the issue of indigent care, but also that different payment structures and different delivery systems are going to carry those costs in different ways and impact. Some are going to take it at the original premium level, some are going to take it behind the actual delivery of services. So, but it does bring up that this is an important dialogue, I think, and particularly around policy. Yes, this young lady over there.
As a physician who had been in the system of Kaiser Permanente, and as a salaried physician, I didn't know whether or not a patient had insurance or didn't have insurance when I took care of them in the emergency room or operated on them. Didn't matter. I was salaried. I was getting paid. All right. So I didn't distinguish who was indigent and who was not. And that kind of philosophy about we take care of the patient when they're in the emergency room, and regardless of what insurance or no insurance, is part of that core value of the physicians of Kaiser Permanente. And so, so it's hospital health plan, and that really kind of looks at those costs. From a physician standpoint, it really didn't matter. And that was the beauty. That was one of the things that attracted me to the organization. Yes.
Is it a different question? Or?
It's a totally different question. What I want to say is I've had purely positive experiences with all 3 of your organizations. I do volunteer work for organizations pertaining to epilepsy. I've had interactions with many people who have epilepsy. The best stories I've heard have been from people who had surgery and have been essentially cured of epilepsy. I've heard other stories about people directly from people who had to take 5 medications and needed a kidney transplant as a result. And the indication is that the insurance companies will not pay for the surgery because they know that the financial benefit will come from future insurance providers. Has any effort been made to acquire funding for brain surgeries from the federal government for people who have epilepsy who are candidates for surgery but whose insurance will not cover it? And if so, I would like to know how you're doing that so that I can help with the process. Thank you.
I can't answer your question specifically about epilepsy, but my best knowledge about it would be to say no, that there is not a specific line item sort of funding from the federal government for it. If you don't mind, I'll use your question, though, to talk about the related broader policy issue. And it is one of those things, when I alluded to the challenge we have going forward, is the whole issue of what's generally referred to as clinical effectiveness. And so the challenge that we have as a country is coming to grips with how to continue to make advances in science and medicine as technology evolves and our ability to treat things evolves, and then how we, at the same time, make the decisions about what will be paid for, whether it's at the federal government level or by commercial insurers. And for the foreseeable future, those are going to go down parallel tracks. The government, as it has already for many years, has had processes in place to try to make those determinations of what Medicare will cover. It's built around the best available evidence that is known. And separate from that and unrelated from it, each individual commercial insurance company will make its own determinations about those things. I think one of the changes coming out of the reform legislation is that over time, I do think you'll see those decisions tend to become more uniform for a variety of reasons.
At Kaiser Permanente, we call it Permanente medicine is evidence-based medicine. So any new technology gets the scrutiny of what's the current most prevalent belief in the medical literature. We have what we call NTET, or New Technologies Assessment Team, that consists of physicians of multiple disciplines that scour the literature and therefore look at what is currently evidence-based and that, to extend that coverage. And if we do not provide it, we do not have the providers to provide certain care within our organization, then we will have those cases sent out. Again, the epilepsy is not my area of expertise, but in general, that's how we handle new technologies. If a new surgical procedure, robotic surgery, hyperbaric oxygen, or whatever it is that we're doing, we look at the evidence with a group of physicians through our NTAT, and then we spread that knowledge throughout the organization. And we evaluate products in that way, same manner. We evaluate pharmaceuticals through regional programs and national programs for pharmaceuticals and therapeutics. So we get the best knowledge that we can at the time. And then we know that technologies change or fall in favor or fall out of favor. And we have to have that ability to go with what's currently the best evidence and then change it as we go forward.
Thank you. We're really out of time. I want to be respectful of our guests who are volunteering their time tonight away from their professions and their families to be with us, and respect all of your time. And I'm getting the high sign and the notes that we've got to call it to an end. I think what this points out, but though, and I'm thrilled there are so many questions, in that this is the first healthcare forum that we have sponsored at the Graziadillo Business School, and that the Graziadillo Alumni Council has put on. And I think it's an indication of hopefully having cause to do these kinds of conversations and dialogues more into the future. And I hope we're able to impose on you all to come back again, because I know I've got a ton of questions for you, and there's certainly more in the audience. I want to thank you truly for leading us in a dialogue, answering some pretty tough questions in a very, very challenging area, and also the responsibility that you all take for leadership in healthcare, just in general as a field in your professions, both at administration and in the clinical areas and the delivery, and being leaders for us here in Southern California. All your institutions are well regarded, and I think they're all lucky to have you. And I think we were to have you join us tonight. So
Great. Thank you very much.
Thank you.
Thank you.
Thank you all.